Hello and welcome to our ninth in the series of Rare Webinars. I'm Nicola Miller, Creative Director at Rare Revolution magazine, and in the background, working on the tech today, I'm joined by my colleague Becky Pender. We're thrilled to have had so many of you register for today, and I would encourage you to take advantage of our great panel by using the Q&A to ask any questions, which we'll get to at the end of the session. In today's session, which is in partnership with Sanofi, we'll be talking with a multi-stakeholder lens about cold agglutinin disease, CAD, and I'm pleased to be joined by a fantastic panel. Professor Catherine Broom, who is a board certified in internal medicine, hematology and medical oncology, Pat Watson, expert patient and president of the CAD Foundation, and Jörg Freitag, expert patient and founder of a Facebook page supporting families in German-speaking countries. Hello all and welcome. Now, I like to start these sessions by going back briefly. So while the panel just join us, Professor Broom, Catherine, if I can come to you first, can you tell us what is CAD and how is it diagnosed?
So cold agglutinin disease is a rare autoimmune hemolytic anemia. So it is an autoimmune disease that is acquired. It's generally diagnosed in the 6th, 7th, or 8th decade of life, although we certainly have seen it in patients much younger. It is comprised of two main symptom complexes. One of them is anemia related to the hemolysis, and that is manifested by fatigue, shortness of breath, sleeplessness, irritability, muscle aches, joint aches, etc. And then the other is the unique thing about cold agglutinin disease are the symptoms that people experience when their extremities or the rest of their body is exposed to cold temperatures. And that causes the antibody in cold agglutinin disease, which is IgM, to drag together those red blood cells in a process called agglutination. And that can result in very cold extremities, fingers and toes in particular. Tips of nose and tips of ears can also be affected. They may change color, they may become painful, and in severe cases, actual death or dying of the tissue causing actual sores might occur.
Gosh, okay. And so thinking about, you mentioned that this is something that tends to happen sort of later in life. Can you talk to us a little bit about the importance of a timely diagnosis and the impact of delaying a diagnosis?
Sure. So, this is one of those diseases where it is oftentimes difficult for a patient to get an accurate diagnosis. I think two things sometimes play into that. Many of the symptoms that patients might go to their physician discussing are very vague, are also very common symptoms. And so a lot of times it's difficult for physicians to put the pieces together to even think to order the correct testing from the laboratory. The other challenge in cold agglutinin disease is that the laboratory specimens must be handled very carefully and very specifically, and they must be kept warm at all times prior to the laboratory testing, or a falsely negative result may come out. So many patients may get the right test, but it may appear negative because the specimen wasn't handled correctly. And I think the importance of a timely diagnosis is because once we have an accurate diagnosis of cold agglutinin disease, there are a variety of lifestyle changes, but also monitoring things and therapeutic interventions that may be appropriate and recommended for a patient. But if we don't have a good diagnosis, then we really can't know exactly how we might help our patients best.
Sure, thank you. That's a really good overview there. I really appreciate that. And Pat, obviously you're based in the US. Can you talk us through your diagnosis and what that journey was like for you?
Well, I had CAD a few years before I was diagnosed. It There were various symptoms, like Dr. Broom said, that the breathlessness, that kind of thing, but I could live with it. I just thought I was getting old, out of shape. That's a common tendency for people to think. So I did start kind of going downhill, more breathlessness, rapid heartbeat, that kind of thing. It as time went on, and I finally got to the point where I was just almost unable to walk. And so I called my primary care doctor, went in, they put me in the hospital and tried to get a good blood test and could not. And then he sent me to, I had a couple of transfusions, came out dancing. I was fine. The primary care sent me to a gastro thinking I had internal bleeding, and gastro couldn't find anything, couldn't get a good blood test. It sent me finally to a hematologist. All of that took about 3 months. And so the hematologist, I was very lucky in that at that time, it's difficult today to get a good diagnosis, but at that time, it was incredibly difficult. And so I went to the hematologist, and luckily, he had seen a case of CAD in his residency. And so he kind of knew, he was a younger doctor. He remembered that. And he tested, gave me the correct test. And that's how I was diagnosed.
A little bit of serendipity there in terms of somebody that had come across this before.
Absolutely. And that's very unusual.
Can I ask how long ago you were diagnosed?
2014.
Okay, fantastic. And Jörg, how does that differ from your experience? You know, what's the diagnostic journey in Europe and Germany look like, and how does that differ?
Yeah, of course, I can only speak for myself.
Sure.
It all started without me knowing that it was called agglutinin disease in 2009, around 2009, where I had difficulties changing tires outside in the cold, and my boys had to help me. At the time, they were 13, 14, and my ears turned blue and almost black, and my hands couldn't work anymore, and I didn't think much of it. Saying, okay, as Pat said, you are getting old. I was at the end of my 40s then.
Oh, help.
But then it gradually got worse until the year 2017, when I decided to go to my, family doctor, and told him that my pain is so strong and that my skin turns so quickly blue, and it turned quicker and quicker into the blue than years before. So it got worse. So my family doctor then said, I don't know much about this, but it sounds like, and it looks like it has got something to do with your blood. So I'll send you to a specialized blood laboratory, which I know in the area. So I went there, and they suspected originally bone marrow cancer. So in the 2 weeks it took them to finally get to the result that I had cold agglutinin disease, me and my wife and everybody close to me were really worried. And then, finally, after 2 weeks after the blood investigations, we got to know, CAD. And then we all started to find out and to start finding out what CAD is all about.
And it's interesting that you both say that actually you could easily mistake the symptoms for kind of general sort of aging process. So obviously that's quite difficult for people to know when is the right time to seek that medical advice. So Catherine, what are the red flags that healthcare professionals should be looking at to make them aware of CAD? You know, how do they differentiate that from someone perhaps coming who's just, feeling out of breath and maybe just could be confused with just general aging?
Yeah, I think having a low threshold for suspicion, and I think, remembering that, yes, we do get a little bit deconditioned, or our lifestyles do change a bit as we do age. But I think, any significant changes in how much you're able to do, how far you're able to walk, and certainly, the symptoms of the painful color changing in your hands and in your ears, all of those things would, warrant, I think, a medical evaluation. And, from the standpoint of clinician patient sort of interactions, I think patients do, unfortunately, have to be their own advocates. And I think if you are not feeling well, and you are not getting an answer, to continue to ask the question, I didn't feel this way 1 year ago, something new is happening. And as mentioned by Pat, a lot of times clinicians are very frustrated with cold agglutinin disease because they can't get a good blood test reading. And the laboratory might say to them, oh, the blood is clotted, or you need to redraw the blood. And, for clinicians, that's one of the first clues that you might be dealing with cold agglutinin disease. And that's a real conversation between you and your laboratory to say, gee, what can we do? We must, try to keep this specimen warm so that we can then get an accurate assessment of what might be going on with regards to the hemoglobin level.
So two things, if I can just unpick a bit there. First is with regard to the color changing. So obviously the pain and the fatigue could, very easily be confused with other things, but color changing is quite a distinct visual sort of symptom here. Does that happen at the onset of those earlier symptoms, or is this something that follows later? Would that be presenting initially when you're getting that first fatigue?
So it's unfortunately varies very widely from patient to patient, how significant the agglutination of those red blood cells is. And it's really that agglutination that causes the color changes. So, one patient like Jorg may have very significant color changes, but another patient may have mostly the hemolysis, or the destruction of the red blood cells, and not very much, or honestly none at all, of the agglutination or the color changes. So it is a disease that has a very wide spectrum of symptoms that can go along, and those symptoms can change with the disease process itself, but it is unfortunately not something that we can say everyone is going to have these particular signs or symptoms.
Sure. And the other thing I wanted to just touch on is, you mentioned obviously that the getting the blood test is quite a complicated part of this puzzle here in terms of diagnosis. So because it's quite a specialist test, would I be right in assuming that the clinician has to have a good indication that this is the condition that they're testing for? It's not a generic test that then yields a diagnosis. This is a test for CAD because that's been suggested as the possible diagnosis.
Correct. So it is a special test that has to be specifically ordered by the clinician. Almost always it's going to be ordered by a hematologist or, a blood specialist. I think that they're the ones that are going to put together some of the results on the more generalized blood testing to think, oh, in order to try to get a more specific answer, I'm going to need to order some more specialized testing. And then again, it's on that clinician to remember that they have to talk to the phlebotomist, the person drawing the blood, and then also the laboratory processing the blood, about maintaining that warmness. And, even the air outside of our body is not the same as our core body temperature. And so, it might not seem cold in the room where the blood is being drawn, but the temperature difference is enough to cause there to be that agglutination within the test tube, and then that makes it impossible to evaluate the blood accurately.
Okay, so it makes those red flags all the more important, doesn't it, to make sure that they go, you know, this directs clinicians down the right route for this testing.
Absolutely.
So, Catherine, can you also just kind of give us an overview from a healthcare professional's point of view? What are the challenges in managing CAD for patients?
I think that there are a variety of challenges. First and foremost is the rarity of the disease, right? Not every clinician is as fortunate as Pat's clinician to have seen a case before. So one, challenge is that many clinicians have never encountered or been responsible for managing a patient. So thinking about this disease is new and different for many clinicians. I think that the dual physiologic action of the antibodies is also a challenge, right? Are they mostly causing the destruction of the red blood cells? Are they mostly causing the sticking together of the red blood cells? Are they causing both? And then, how do I think about addressing those specific things that might be happening in my patient at any particular time? Luckily, there's been a lot more awareness of CAD. There's been a lot of new data that has come out in the literature about CAD as well. It's really not the benign disease that we may have thought in the past. It is a disease that deserves our attention. It deserves an accurate diagnosis, and it really deserves a directed approach to therapy.
Brilliant, thank you.